Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on Seroquel, Quetiapine. I recently did a video on the armamentarium of medications that's available to us for the treatment of insomnia, just sort of the general classes that I think about when a patient comes to me complaining of insomnia. But I forgot to mention Seroquel, Quetiapine, which is probably used more frequently to treat insomnia than it is even for its FDA-approved indications. It's primarily a second-generation antipsychotic agent and mood stabilizer, but it is used a lot, especially by primary care for the treatment of insomnia, and it's definitely not the best choice for that type of treatment. Initially, I was quite loath to use Quetiapine for sleep because of the risks of tardive dyskinesia and metabolic syndrome with chronic use. We're trying to rule out type 2 diabetes and dyslipidemia, elevated cholesterol, or a bad HDL to LDL, good and bad cholesterol ratio. But Seroquel is a low-potency agent, so the risk of tardive dyskinesia, TD, is much lower than with the higher potency agents such as Risperdal or the first-generation antipsychotic Haldol. It is a cumulative risk, so dosage and potency are important over time. As far as metabolic syndrome, that's something that can be monitored for in the short term by monitoring a patient's weight and measuring their girth as measured at the umbilicus, as well as by following lab work. So my opinion on this has since softened a bit, and I think that we can probably justify its use in low doses over short periods of time, particularly in those patients who might benefit from Seroquel's other pharmacodynamic effects beyond simply sedation. It can help the mood. Though at the doses that it's used for sleep, it's probably not going to. It's probably not going to touch the mood. It's still not one of my first-line agents, certainly, but whereas I used to move patients off of it, patients who would come to me and they were already taking it because they had been previously prescribed it by another practitioner, I would dismiss it. I would explain to the patient why I didn't like to prescribe it, and I would take them off. Now, I'm not so quick to take them off if they're doing well on it, but I still explain to them what the risks and benefits are so that I can make sure that we have informed consent moving forward. And I'm still loath to continue taking it for a long time. So that's probably why I forgot to mention it when I was talking about all the things that I think of when it comes to treating sleep. But many of you out there maybe have been prescribed it for sleep or are taking it for sleep. And so I wanted to cover it briefly. And I thought I'd go ahead and talk to you about Seroquel in general beyond its use as a hypnotic agent. I don't know how the use of Seroquel as a sleeping pill got started. It's definitely something that's beyond the scope of what it was intended to do or what an expert psychopharmacologist would think to do. Particularly with so many other options available to us, it's probably safe to use. I had one patient that did develop diabetic ketoacidosis while she was taking the maximum dose of Seroquel. I do think it was the Seroquel that caused it. It was a medical emergency and she was rushed to the hospital. However, she was a patient with psychotic bipolar disorder who got psychotic very quickly, and Seroquel serving both as her antipsychotic and her mood stabilizer, and she's still on it. So now she's being treated for type 2 diabetes, but she's taking Seroquel plus some Risperdal, which is another second-generation antipsychotic agent. And she's doing very well on that combination. But when you're talking about patients who don't ever get psychotic, who don't need a mood stabilizer, who don't even have depression necessarily, I just think it's a poor sleep aid because there are so many other medications that are available that don't have those risks. So even if the risk of tardive dyskinesia is theoretical, and even if the risk of metabolic syndrome can be monitored and managed, there are a lot of other medications. It causes sedation through its potent histamine type 1 receptor antagonism, so it's an antihistamine, a prescription strength antihistamine, and there are certainly other psychotropic medications that have that same mechanism of action that might be just as useful, that wouldn't have that problem. So please see my recent The Insomnia Armamentarium video for more on the different classes of medications that are available to us and what might inform our choice of one agent over another. Regardless, Seroquel as a hypnotic agent is in widespread use, and again, it's probably not so harmful in the short term. So I just wanted to say that. I wanted to add that as a coda to my last video. The sedating action, as we've said, is due to blocking histamine type 1 receptors. The usual dosing range is 400 to 800 milligrams for schizophrenia and mania. Bipolar depression can typically be managed with a daily dose of 300 milligrams at bedtime. When clinicians use it off-label for sleep, though, they use a tiny dose. I'm talking about the starting 25 milligram dose and usually not exceeding 150 milligrams or 200 milligrams at the very most. Really, for sleep, 200 milligrams is really on the higher end. So we're definitely exploiting a side effect at these very low doses. And we can't assume that if you give somebody 25 or even 50 milligrams of Seroquel, that we're getting any benefit for the affective or cognitive symptoms simply because we're using Seroquel as a hypnotic agent in those patients who may need antidepressant adjunct therapy. In those patients, we really need to consider increasing the dosage or using a different agent. You can't titrate the dosage too fast or a person might fall down. Seroquel can cause orthostatic hypotension. I have a whole separate video on antipsychotic side effects, a separate video that talks just about antipsychotic side effects, including tardive dyskinesia and metabolic syndrome and some of these other things. So Seroquel is rarely lethal in overdose by itself. It is approved for long-term use in schizophrenia and bipolar. It's not habit-forming, but all psychotropic agents should be tapered and weaned prior to discontinuation, particularly if we're on the higher doses. This is to prevent rebound symptoms. I'm kind of glad that I left it off as a sleeping pill in that video because really it's not a good choice, and it's best reserved as monotherapy in appropriate doses for its FDA indications, and that includes somewhat lower doses to treat depression, particularly in patients with bipolar depression and psychotic patients who are also depressed, and as an adjunct to treatment-resistant major depression. Thank you for listening. Comments are always welcome.